Um, I will discuss with you today for the next 20 minutes about my understanding and some proposal or my experiences in our Drugs and Therapeutics Committee because we are struggling with this problem all the time. This is my conflict disclosure slide. I'm not going to go through each one of them. You may wonder why my clinical program receives funding from Beer Canada, but we have alcohol helpline in the mother risk program. That's why. So, definition of off-label use of drugs. Probably I don't need to explain much, but basically anything outside the use of drug specified in the labeling is off-label. So if you go into the off-label, there are so many elements or categorizations, so it's almost impossible to actually classify or describe the categories of off-label. So it's better just say anything outside the labeling is off-label. Because each jurisdiction has authority to derive labeling, there is a labeling inconsistency among jurisdictions. As you can see, this slide about valganciclovir for transplant patients and cytomegalovirus infection. In some countries, it's on-label. In some other countries, it's off-label. Children, off-label. Adults, on-label. Actually, this slide, I prepared this slide in the help of Dr. Sachiko Tanaka, one of my research fellows. And you know this example of domperidone, which in the US, it's not even authorized. But in Japan, it's on-label, and then in Canada, on-label. So it's really jurisdiction dependent. And another characteristic is that off-label use is prevalent when the disease severity is increased, like intensive care unit, probably PICU, NICU. The use of off-label use of drug is prevalent. So what are the problems? Off-label itself doesn't seem to be a major problem, but what are the problems? The problem is off-label use is often associated with the absence of sufficient scientific data or information. So in other words, the problem is the lack of evidence. So off-label is a surrogate or biomarker of off-evidence use of drugs. The second, some people even say maybe off-label use of drugs tend to have more unintended consequences. I have to actually rephrase this because unintended consequences of drug effects have nothing to do with actually labeling or off-label or on-label. It's an independent factor, so I have to rephrase it as unanticipated consequences. Basically, we don't know what to anticipate because there is no data, so that's the problem. So let's take a look at if the first notion is really correct. So in this paper, the authors checked millions of prescriptions issued by the US private practitioner. So those are off-label use, total off-label use. As you can see, only quarter of off-label use was basically based on the evidence. The rest are without evidence, used without evidence. So that red portion, off-label and off-evidence, That's the major problem. Actually, I was surprised to see this figure. It looks like way over what I was expecting, but that's the data published about 10 years ago. This table shows that off-label use of drugs are associated with the little higher incidence of adverse drug reaction in both inpatients and outpatients. I don't know if they made clear distinction between off-label and off-evidence, or off-label but on evidence. So I really don't know if they made a clear distinction, but those are the numbers you can see in the literature. So what we are doing in SICKs. So this data was provided by Dr. Elaine Lau and Gloria Lim, SICKs Drug Information Service. So out of about 550 entries in our SICKs formulary, about half is off-label. There's no mention of children in the labeling of those drugs. About half, there is a labeling indication and dosage. You may wonder what that 10% unknown means, but we just couldn't get the product monograph and examine it. So it wasn't listed in the Health Canada website. So half off-label, even in our formulary. If you look at the neonates, where which Martin is Martin's practice field. So in neonate, 100 neonatal formulary drugs, more than 70% basically is off-label, even listed in our formulary. So I repeat here, the problem is not off-label per se. Some people say the off-label is not the problem as long as it's reasonable and appropriate. So as long as there is okay evidence, it's okay to use the drug off-label. The problem is when it becomes off-evidence, off-label and off-evidence. So let's summarize what we have been discussing using landscape of medicine use. So human use of medicine may be divided into research use and clinical use. So clinical use, that's what we are talking about right now. I'm not going to touch the research use, which is under the RAB framework and the research. Basically, this is the investigational use of drugs. Out of the clinical use of drugs, fraction of them have labeling. It's on label. The rest are off label. But as you can see, there are groups of drugs which are off label, but there is probably sufficient evidence to use it, mainly in the pediatric field. So it's our own evidence, own knowledge, but off label. So what we should do? What we should do is to reduce that outer area, which is off-label and off-evidence. How to reduce that group of drugs? So this is what we want to eventually do. We want to shift that group of drugs into research domains so that we can get enough evidence for future use in the clinical settings. Now, in any institution, this is our SICKs formulary. The procedure is the same. Prescriber requests the formulary addition, and then Drug Information Service of pharmacy does the in-depth search and then review, and Pharmacy and Therapeutics Committee or Drugs and Therapeutics Committee makes a decision, and we maintain that database, formulary database, on a regular basis. So in other words, formulary is our evidence base. The drugs listed in our formulary is basically drugs which are on evidence. And the prescriber uses our formulary to treat the patients. However, There are situations where those prescribers use drugs off evidence, meaning off formulary. So maybe not listed in the formulary, or not, the use is not listed in the formulary. So it's off evidence, off formulary use. So we have to monitor those usage to reduce that particular group of evidence of label drug use. So in my view, there are probably two major ways to do it. One is at patient or institution level to monitor of evidence use. I'm going to give you one example. The other is a systematic system change, which is outside the scope of institution. It has to be done in national level or provincial level. So here is the example at SickKids about 12 months ago, I think. So we call it innovative drug use designation. It's an intravenous lidocaine use for patients, children with chronic pain. Intravenous lidocaine for children with chronic pain. So in adults, there are several randomized trials and quite a sufficient data, but in children, there is no clinical trial. So anesthesia requested the addition of this to our formulary. So we reviewed the literature carefully, and this was what the committee decided at the end. So we designated this intravenous lidocaine for chronic pain as innovative drug use. So this was taken from our SickKids policy document. When there is not sufficient evidence to support the use of the drug, we call it innovative or experimental. So what it means is that the final decision is, first of all, prescriber has to discuss the plan of use of that drug with the person in charge of the clinical program and get some consensus and then start. And then inform the consent from the parents. Now, if the usage is 1 or 2 occasions per year, this is okay. This is good, and we can put it in the formulary. But if it's more than 3 or 4, we strongly recommend to do it in a research setting. So RAB approval is required, and it has to be done as a research project. Fortunately, in this case, the anesthesia was able to secure internal funding to actually launch the lidocaine, intravenous lidocaine used for chronic pain as a research project. So now it's started. And then we hope the evidence obtained from that study will be fed back to our formulary so that we can have better description of the usage in our formulary in the future. So that's how we monitor the off-formulary usage of the drug and then push the prescriber to do a research project. But the problem is, of course, Drugs and Therapeutics Committee doesn't have a budget to support that kind of research program or research project. So prescribers, we can tell them to do it, but they have to find the money to do it. So that's a kind of gap between what we want to do and then and what exactly happening in the institution. Now, the second is the system change in a more wider level. I have to apologize that I forgot to translate Japanese to English but it's better than Martin, who used the slides written in Dutch. All slides are written in Dutch, so I have only one slide here. So what it says is that legal environment of off-label resolution in the United States. So as you know, 70s, as early as the 70s, and then late 90s in the U.S., there are lots of legislative changes have taken place, and now children-focused PREA and the BPCA are now permanent law in the U.S. The EMA around 2007, I think, the similar legal environment was established. So the things are moving in the right direction, and as you can see, the outcomes, number of pediatric studies to even influencing the labeling have skyrocketed these days. So there's a clear outcome, and then now much clear indications and usage or information is available. However, as you can see in Institution of Medicine report indicates, this was actually published in 3 years ago. This report highlighted several leftover items which we need to tackle. One is neonates. We know really very little about drug use, dose, effectiveness, and safety in neonatal period. Number two was, I think, a painkiller. Although we use painkillers in children a lot, we don't seem to have well-established dosing and effectiveness monitoring safety profile. We don't have enough evidence compared to adult field. There are many other, there are 2 or 3 other recommendations this report stipulated, but still we have to realize that there is a long way to go. So I think this is my last slide, and then I want to thank you for attention. Thank you very much.